Alright, welcome back. So this is the third lecture about shoulder mechanics, and we're going to focus this one on the glenohumeral joint, or the GH joint. So one of the things you'll notice about the Levangie textbook is that each one starts with this muscle actions table for the specific joint and function, and they divide this up into primary movers and secondary movers. So you take something in the sagittal plane such as shoulder extension, and you see that you have the deltoid and the lat as the primary movers for extension. They are going to generate the most force when that movement is being performed. And then you have some secondary ones over here. Adduction, similar as well. So the coracobrachialis, for example, you think of that more so as a shoulder flexor, although it's still considered a weak shoulder flexor. It's a secondary mover for that. But if it were to be with the arms away from the body, the coracobrachialis would be in a position to bring the humerus towards the body, so that's why it would also be an adductor. So these are good things to look at just to refresh yourself and to cross-reference with anatomy to see if anything is different. But as we go through the different joints, thinking about which muscles are primarily moving those joints and which ones aren't. This slide is just a summary of the rotator cuff, or we sometimes call those the sits muscles. Just to remember them, you have the supraspinatus obviously helping slightly with abduction, although considering it's not a very large muscle, but it does help with abduction. And for spinatus and teres minor are both going to contribute to external or lateral rotation. And then you have your subscapularis contributing to medial or internal rotation. So you have the glenohumeral joint pictured here. There's the glenoid, the socket portion, which is concave. And then you have your humeral head, which is the convex portion, and that is making up the ball and socket joint, which of course is a diarthrodial or synovial joint. Because it's synovial, that means it has a synovial capsule. Ultimately, each synovial capsule has two layers to it. There's the inner portion, the synovial layer, and then there's the outer fibrous portion made of denser connective tissue. There are two surfaces for this, both on the glenoid and the humeral head. It is lined with that articular cartilage or the hyaline denser packed cartilage. And the other thing I'd point out on this slide is you have the acromion obviously here and the humeral head here. So this point right in here below the acromion and above the humeral head is typically referred to as the subacromial space, or also the suprahumeral space. Now in this picture it looks relatively small, but that's really just this angulation. It is slightly larger than that if you were to look at it from another angle. We'll talk more about this later. Alright, for this next slide, I thought I'd introduce a new segment to these online lectures, and that is cheesy joke time. Luckily for you, I found a website full of cheesy jokes. Cheesy like dad jokes, I think. Okay, so today's joke is, what do you call an alligator detective? An investigator. Okay. Okay, that's the end of cheesy joke time. So we can get back to the rotator cuff. So one of the things that we're always wondering about is how to preserve the function of the rotator cuff. The question here is, what do all rotator cuff muscles have in common? A very important point to make is that the connection between the scapula and the humerus. All rotator cuff muscles are going to start here on the scapula, and they're going to attach into the humerus. And so functionally, when they contract, they're going to basically be pulling the humerus back into the glenoid. So all four rotator cuff muscles provide stability. For the joint. Consequently, this is most important with any type of overhead actions, so generally over 90 degrees, or anything involving a high velocity. So whether that's serving a volleyball, a tennis ball, overhead throwing, reaching quickly overhead, these rotator cuff muscles are going to act as strong stabilizers. So in addition to the individual functions they perform, abduction, internal, external rotation, the key component is this dynamic stability of allowing that humeral head to stay close to the glenoid, keeping the ball in the socket. In terms of the kinematics and the motions, there are three degrees of freedom generally for the glenohumeral joint. Flexion we'll abbreviate with a check mark, typically in our documentation. Extension with a slash. You have abduction. Abduction generally we refer to that as ABD or ADD. Abbreviation. Medial rotation is often called IR. Internal rotation, lateral rotation is often called ER for external rotation. In addition to these motions, we do also recognize the glenohumeral joint does go through circumduction, and it also goes over horizontal abduction and horizontal adduction, and we can demonstrate those in lab. For the available range of motion into flexion, there is typically 120 degrees, but you might be wondering, well, I can get my arm completely over my head 180 degrees. 180 degrees is going to be with including the scapulothoracic motion, and also the AC and SC contributions to that. Extension is much less limited, but with this, the glenohumeral joint, along with the other joints, make the shoulder the most mobile joint in the body, so it's very important to keep stability with that joint. In terms of the arthrokinematics, flexion here is going to be a superior roll, and that's going to be partnered or coupled with an inferior glide. So that's similar to the SC joint. So abduction, similar in terms of the roll and the glide. With flexion, it's going to be superior for the shaft of the humerus for the roll, and then the humeral head is going to be doing an inferior glide. Another thing you can appreciate on this picture is the subacromial space and how limited that is with the humeral head and the acromion, so that if you don't have the inferior glide of that, the humeral head is going to impinge upon anything in the subacromial space, namely the supraspinatus coming right through there. There are other structures as well, but that's a common cause of what we call subacromial impingement syndrome, is not enough inferior glide. And then the last two motions that we're most interested in, the glenohumeral joint, are the external and internal rotations. This joint is, if you're taking an aerial or superior view of the shoulder joint, you can see that the slide is as pictured here, or glide and roll do occur in opposite directions. So external rotation does cause a posterior roll and an anterior glide, whereas internal rotation causes the opposite, an anterior roll and a posterior glide. And these are often assessed with your arthrokinematic joint play feels and determine what's limited. Although this is based on the convex-concave rule, there are many exceptions to this. We have to also take into account the patient, client, or athlete's posture and position. If they have a very forward shoulder position, then these might be altered. But this is a good rule of thumb for this. And that is the end of this lecture. Thank you.